the standard therapy, all of bacteriophages for urinary tract infection by Alexander Uzma-Jurije. I don't know Alexander personally, so I wanted to ask Nina if Nina, you can please introduce Alexander. We are very much looking forward to hear his presentation. So,
Nie, tylko tyle.
Hello. So Alexander.
And Christo.
Yeah, I'm here. Alexander is a doctor from the Center of Urology in Tbilisi, which is the biggest center working in this field. And I would say that all clinical trials were on the shoulders of Alexander Uzma-Jurije, and he was the person who was the most dedicated to this project. And if we have some success, this is his contribution, his merit, first of all. And as a young scientist, this is the topic of his PhD thesis. So I hope very much that soon we will attend his defense. What else can I tell you?
I think that's that. So we are looking forward to. I think that we can pass it on to Alexander to tell us about the details and the results of his studies. Alexander.
Thank you very much for the invitation. I'm thrilled to speak in front of these amazing colleagues. Thank you, Nina, for introduction. I'm a urologist working at National Center of Urology here in Tbilisi, in Georgia. I'm a head of urolithiasis department. It's stone management and treatment department, and was participating on this trial, which I will present today, about the phage treatment of urinary tract infection, patients with urinary tract infections, alongside with my colleagues in National Center of course, from colleagues from Eliava, and also the collaboration with colleagues in Switzerland. So the problem itself is quite big in urology. This is the urinary tract infection problem, and it mostly occurs with the patients having enlarged prostate, let's say. Its diagnosis is the prostate benign hyperplasia. It occurs in about 25% of all men at age about 13 years old, and in about half of the men have this diagnosis at age of 80. So the surgical management itself is a transurethral resection of the enlarged prostate. It still remains the golden standard of the surgical treatment, despite some variabilities in procedures, but it stays almost 100 years as a golden standard of the treatment. So to explain this treatment, it's not complicated. It's a special instrument. We are assessing the prostate and the bladder via urethra, and this, you can see the instrument is called resectoscope, and resection is made. We take bit by bit the enlarged prostate to make the urine of the patient after the surgery to flow better, to feel better while urinating, and to remove the symptoms that they have, like retention maybe in some patients, and nocturia. They often stay to urinate during the night a couple of times, some reports every hour, let's say, and their life is quite difficult and disturbing, the symptoms. So during this procedure, after this procedure, the bladder neck is widened and the enlarged prostate is removed, so the voiding of the patient gets better. But we do use catheters before. Sometimes, if the patient has a urinary retention, they have urethral catheters sometimes, or sometimes suprapubic catheters, even before the operation. After the operation, they also they have these catheters and the irrigation. I will explain it later. So before the wounds, let's say, heal, and they can void themselves after some time, after a couple of days after the operation. And the catheters, are problematic for the patient in terms of becoming the cause of the infection. The urinary tract infection is one of the commonly used diagnosed infection in older adults, and after the age of 15, almost half of men experiencing UTI, and they are usually associated with the BPH that I was talking about. So the significant role also lays on the residual urine. These patients have, after the voiding, the bladder retains some portion of the urine, so it's the growth medium for bacteria. So UTI is very common on these patients. Statistically, it's 7 million physician visits annually in USA. It's a huge number, if you agree. And approximately 15% of the all community prescribed antibiotics are cause of urinary tract infection. The catheters itself are quite problematic, as I said, and the bacteriuria in those patients occur in about 25% if the catheter is placed more than 1 week, with a daily risk of 5 to 7%. Even a single insertion of the catheter can cause the bacteriuria in 1 to 2% of cases. And especially if the catheters are open drainage systems with if they are not closed drainage systems, almost in all cases, after a couple of days, there are bacteria in urine. As of urological boards, we are reported that there are 10 to 12% of patients becoming the healthcare-associated infections. And we all know that these infections are so-called superbugs, resistant to many of antibiotics, and are a huge problem. So this trial consisted, let's say, with a couple of parts. First part was in vitro part, let's say, phage cocktail adaptation cycle, which started the preparation for the trial itself. The second was, I would say, a test run with the patients who are already have been treated in our clinic. So it wasn't blind treatment; it was open label treatment. And the third part was the trial itself, after the whole preparations we've done to start it. So the first steps started in Switzerland. Our colleagues in Zurich University Clinic in Balgarist Clinic, they collected samples from 50 patients. Urine samples were sent to the lab in a laboratory to prepare to send it to Eliava, and these samples were afterwards sent to Georgia in Eliava Institute. They reported that cocktails that preparing Eliava Institute called PO Bacteriophage, one of the cocktails reported 66% of success rate, and the NCO Bacteriophage even higher, 93%. And after the adaptation cycle of PO Bacteriophage and NCO Bacteriophage, they achieved even higher percentage of lytic activity. So the E. coli strain, only one E. coli strain remained resistant. All other E. coli strains were affected by the bacteria cocktail, and the bacteriophage of Eliava collection could lyse all three pneumonia strains. So it was quite a good start. After that, the collection of the urine samples from patients started in our clinic in Georgia. So from September 2016, we collected 130 patients' urine who were also planned for TURP in our clinic. And statistically, the majority was E. coli and Enterococcus, which is common infection in the urinary tract infection. So urinary tract, and this collected urine were also sent to Eliawa, and first the phages, bacteriophage cocktail showed activity only in 24%. 16% were intermediate, and 60% were resistant to the phage cocktail that Eliawa were producing at that time. And also on this urine samples, cocktail was enhanced, and the adaptation cycle was also processed. And after the adaptation cycle, the enhancement of the sensitivity was almost 75%. So it was also the cocktail was also significantly better after the adaptation cycles than before the adaptation cycle. So this we proceeded with the preparation, let's say, test treatments, because I shouldn't use test, because the bacteriophage is widely distributed in Georgia. We use it as a treatment method, and it's registered as with antibiotics. Also, the phages are also registered as a treatment medication in Georgia. So we treated 9 patients with a reliable infection that we sent out to Eliawa, and it was confirmed that those 9 patients have sensitivity tests with the phage cocktail that we were intended to use. In 6 out of these 9 patients, the bacteria titer was decreased. So after that, we processed with the trial itself. So the plan was to execute the trial within 2 years, to include 81 patient, 27 patient per group, 27 patient in a placebo group, 27 in antibiotic group, and 27 patient in phage treatment group. After the randomization and prospective data collection, we should analyze the data and hopefully wanted to publish the results. So we started. Of course, we were using the PO bacteriophage, which is available in Georgia in pharmacy. You can freely buy it. So we used this cocktail. So it was designed as a randomized placebo prospective double-blind trial. As a National Center of Urology, we were the patient treatment site. Eliawa Institute of Bacteriophages, Microbiology and Virology in Tbilisi, they were preparing the bacteriophage and the placebo. Also, the adaptation cycle were proceed during this whole period. So, and also, of course, neurology, spinal cord injury, and the Belgrist University in Switzerland, both were contributing to study design, monitoring, and statistical support. So initially, we come up with a very complicated trial structure after the collecting urine, if the inclusion criteria were fulfilled, randomization, and patients were placed in the bacteriophage or placebo or antibiotic treatment groups. After the treating for 7 days, unblinding were planned, and if patient had no bacteria, of course, the study was ended. But if the bacteria remained in the urine, we wanted to distribute them in a second phase. If the prior bacteriophage treatment, they would receive the antibiotics. If placebo, they will proceed with bacteriophage, and if the prior antibiotics, so the phage or antibiotic treatment were processed. But this we treated, as I was saying, pre-trial 9 patients, and there was obviously problems with the logistics and everything. So we decided to a little bit simplify the trial. So we come up with the only first step and removed the second step. So not to overcomplicate things and to get the primary results and to get the patient treatment as safe as possible. So the inclusion criteria, standard as everyone else. So we plan to the transurethral resection of those patients and checked for UTI. If the UTI, the eligible microorganisms were suited for the PO bacteriophage cocktail that we were using. Also, the sensitivity was checked, and the if the cocktail was working and the sensitivity was positive, so the patient were included. Patients under 18 years old, patients with the symptomatic signs of UTI with chills or any inflammation or acute prostatitis, of course they were excluded from the trial, not included in it. And also the treatment of antibiotics, they also sometimes some patients receive antibiotics prior to operation, so it was also mandatory at least 7 days not to have any antibiotic treatment done for those patients. So the patients underwent the TURP and received 20 milliliter twice a day for 7 days. The phage cocktail was introduced either from bladder or urethral or suprapubic catheters. Both catheters were closed, and we intended to stay closed about half an hour, maybe an hour. It depended on the irritation symptoms. If patient after half an hour wanted to urinate, they were saying that the bladder is full. Of course, we were opening these drainages and let the urine and the bacteriophage cocktail to come out. So post-op lab tests and follow-up for at least 30 days were made. All these data were collected in RedCap system. It's online database. So blind treatment was with no issue. We all had our permissions there. So as a result, between we started at June 2nd of 2017 and ended up including patients in December of 2018. Overall, 400, about 500 patients were screened for reliability, and only 113 patients were randomly allocated to the treatment. So 37 patients are reported in the bacteriophage, 38 in placebo group, and antibiotic treatment group was included with the 38 patients. So primary outcome of the trial was microbiological treatment response, the lowerness of the bacteria titer in urine, and also the secondary outcomes were the safety parameters and urine assessments of microbiological and also the improvement of deterioration of the UTI symptoms. So lots of data collected. It included the pre-operation IPSS, it's the International Prostate Symptom Score, Euroflow, how they were urinating before and after the treatment, Bladen diaries, PSA, it's a prostate-specific antigen, indwelling catheter days also were written down. So the urinalysis, of course, and sampling bacteria, also the surgical characteristics as a duration and resectant tissue and so on. After the TURP, the resected tissues are sent to morphological laboratories in case of malignancy, post-operative, and to assess those patients if there is a malignancy with the treatments after the operation. So as a result, all three groups showed similar results in case of primary outcome and secondary outcomes, also in adverse events. So Bacteriophage primary outcome, the lowering the titer was in 18%, placebo group 28%, antibiotic group 35%, and reduction of the titer of the infection in urine. In Bacteriophage, 7 out of 28 patients, placebo group 12, antibiotic group 18 patient in 30 out of 37. So the adverse events were reported in 29% of cases, but there was no significant difference in between the groups. And these adverse events were mostly fever, and they didn't cause the prolongation of the hospitalization. So after the fever, patient underwent the standard of care, the antibiotic treatment chosen by the antibioticogram, which we did prior to surgery. So we can discuss that intravesical bacteriophage therapy if done prior to TURP might have resulted in a higher success rate in case of in favor of bacteriophages, maybe, and the dropout rate was quite high. We tried to include and screened about 474 patients, and only 113 were included, so less than a third. And also, in case of Bacteriophage cocktail, no detailed classification and description of the concentration inside of the bacteriophage cocktail is done. So this is also the way we can discuss and we can improve on. Management, so as a conclusion, we can say that management of UTI in patients undergoing transurethral resection of the prostate is similarly successful irrespective of treatment chosen, like we choose antibioticogram prior to as a standard of care. We can choose the bacteriophages and also the irrigation, which is done after the operation, also makes its role to have lower incidence and lower effects, so lower the fever or any side effects of the patient. So maybe future trials will do better in terms of changing the treatment procedure. Maybe we should do not twice a day 20 milliliter, maybe 40 milliliter was better, or maybe 3 times a day. We should discuss this, of course, and hopefully we will see in future trials the answers for these questions. Also, the personalized treatment, the bacteriophage cocktails could be improved the way that patients receive not only just generalized cocktails, but more specifically to the bacteria that specific patient has. So it also should theoretically increase the outcome. So I wanted also to say the huge thanks for the huge group at Eliawa Institute, groups of scientists who done a very huge job preparing and combining all this trial with us. We contributed as a site of the trial, and also our colleagues from Switzerland. These trial results were published last year in September in the Lancet Infectious Diseases, which was, for me personally, was a quite, let's say, how to say it, with all this pandemic going on and all the viruses and all the huge amount of trials going with the COVID-19, our trial, including our trial in in such a hugely respected paper in that year was, let's say, quite strange.
A big surprise.
Yeah, a big surprise. Yes. So thank you very much for listening, and if you have any questions, I would like to answer. Thank you.
Thank you very much, Alexander. That was very nice. We can close the slides if you want.